Today we are going to study about a very important topic for your NEET PG as well as for your university exam of your final year MBBS, as this topic is also important for NEET SS as well. So the topic of discussion is endometriosis. Endometriosis. Okay. So what is endometriosis? This endometriosis is nothing but presence of the functional endometrium presence of functional endometrium outside the uterus outside the uterus. Okay, so this endometriosis is a very it's a benign condition where what is the common symptom that is being seen is two important. One is pelvic pain, and next is infertility. Okay, infertility. So so this endometriosis generally it affects the reproductive age group people. reproductive age group Reproductive age group people. Okay, so initially the prevalence is 5 to 25%, and now the prevalence has been increased up to 30%. This prevalence have been increased 30% is because of over diagnosis. Initially, there were no large amount of parameters to diagnose, but now we have a large amount of parameters to diagnosis. So that is why the prevalence has been increased. Okay, so now this is about the basic features that about the endometriosis. No question will be asked regarding this in your NEET PG. Okay, and now before going to this, let's discuss a little bit about the anatomy. So now in this anatomy, you have to know few structures to understand the endometriosis. Okay. So as you know, this is urinary bladder, and this is uterus, and this is rectum. So in between the urinary bladder and the uterus, there is a small pouch, and that pouch is vesicouterine pouch. That is a vesicouterine pouch, which is important. And there is a space between the uterus as well as the rectum. That space is nothing but called, here it is not given, it's called POD is nothing but called as pouch of Douglas. Okay, and now there is a small pouch between the upper part of rectum as well as the uterus, and that is called as rectouterine pouch. Okay, and sigmoid colon you should know, sigmoid mesocolon you should know, and yeah, ureters, of course you should know about the ureters as well. So why I'm telling you about this rectouterine pouch and vesicouterine pouch, you will know in further details. Okay, so this is about the anatomy. If required, we'll come back to this anatomy again. Okay, so this endometriosis is a it's called as enigmatic disorder. What is enigmatic disorder? See, enigmatic disorder is nothing but called as a disorder which cannot be told perfectly. So there are some theories which will justify the disease, that is called as enigmatic disorders. Okay, so this endometriosis cannot be told perfectly why it is happening, but there are multiple theories where it is explaining about the endometriosis. Okay, so first theory is Samson's theory. So this is little important. They have asked in a university exam as well as for the NEET PG as well. Okay, there are few points which they have asked in NEET SS. Even that points we'll discuss. Okay, Samson is a person who belongs to United States of America. Okay, so he is basically a gynecologist who has done a lot of work on the endometriosis. What he did is he just did a laparoscopic surgery. He did a laparoscopic surgery during the menstruation. Okay, during the menstruation. Then what did he identify? For example, you think this is the uterus. Okay, so he identified that during menstruation the blood is coming here back. Okay, through the fallopian tube, it is coming out. So what is present here? Once it comes here, the blood gets accumulated in the dependent part. Okay, just now I told you what is the dependent part. Here, this is the dependent part, the pouch of Douglas. So the blood comes, and this amount of the blood, there is a ovary here, so little amount of blood will come and attach to this ovary also, and it will come and accumulate in the dependent part, that is pouch of Douglas. And when it is coming, the posterior part of the uterus also will get held with a few amount of this endometriotic tissue. Okay, so with this theory, what he is telling is, the blood, instead of coming down, the amount of blood is going back. That is called as retrograde. That this point is very much important. This point is very much important. Retrograde flow of fragments of endometrial tissue. I am writing all this because this is a very important point. Through the fallopian tube into peritoneal cavity. Okay, so this is the important statement that you have to write during a university exam, and this is the same statement that they give during your NEET PG as well. So this is nothing but called as Sampson's theory. Okay, but is this Sampson theory explaining properly about endometriosis? No, it has some cons as well. What are the cons that it has? Is, first and foremost, it cannot explain the distant endometriosis. What do you mean by distant endometriosis? Is, for example, if the endometric tissue is present far away from the genital tract, that means whether it is present in the lungs, pleura, near umbilicus, etc. So this theory cannot explain this. And second thing, what they're telling is, generally 90% of females will have retrograde flow. But all this 90% of the females are having these symptoms? No. So only the 10% of the females are having this endometriosis. Okay. So this theory is not explaining these two things. But this theory will explain, it has proofs. It can explain why the endometriosis is present in the most common site, ovary, pouch of Douglas. I told you there, utero-vesical peritoneum, uterosacral ligament, and of course broad ligament. So if there is a retrograde flow, obviously all the structures will come in contact with the blood. So then all the endometric tissue which is present in the blood will get deposited there, will get fixed there, will get penetrated there. So this theory can explain all these things. Okay, so this is about the Sampson's theory. And here what are the questions they have asked in a NEET PG is, first thing, what cannot it explain? It cannot explain about the distant endometriosis, and it cannot explain about why only 10% of the females who is having this retrograde flow will have these symptoms. So these are the two MCQs they have asked in your NEET PG. Okay, and next, what is the next theory we have? Next is coelomic theory, coelomic metaplasia theory. Okay, what is coelomic metaplasia theory? So this coelomic metaplasia theory was told by two important gynecologists. One is Mayer and Ivanoff. Okay, in the year 1919. If you want, you can remember, or else you don't need to remember. Just that it's easy to remember, I just wrote it. Okay, so what they're telling is, there are two types of peritoneum. One is parietal and next is visceral. This parietal peritoneum, okay, this parietal peritoneum is generally pluripotent. It's generally pluripotent. What do you mean pluripotent? It can give rise to certain type of cells. Okay, so what happens is it undergoes the metaplastic transformation into the endometrial tissue. So it can undergo metaplastic transformation into the endometrial tissue. Okay. Okay, so this can undergo into the endometrial tissue. That is nothing but called as metaplasia. And now, the same epithelium which is present on the ovary and the endometrium and peritoneum all arise from the same totipolar coelomic epithelium. Okay, what are the things? One is ovary, one is endometrium, and next is one is peritoneum. So, generally, peritoneum matlab pelvic. All these three arise from the same totipotent coelomic epithelium. Okay, so now we can tell. So now, since all these are coming from the same totipotent coelomic epithelium, if the parietal peritoneum is having the same ancestor totipotent cells of endometrium, so that will be converted into the endometrial tissue, and this endometrial tissue will be functional and it will be hormonal functional, and it will try to bleed and form all the endometrial tissue. You understood? Okay, so now what is the benefit of this coelomic metaplastic theory? How is it beneficial when compared to that of Sampson's theory? What does it tell is it basically explains about the unusual site. Unusual site. What is the unusual site that I've told you? Especially if the girl, see, generally in Sampson theory what they're telling is retrograde bleeding. So if the bleeding is happening in the back, that means backflow, then only the endometric tissue is present in the pelvic region. But what are the usual sites? Usual sites are the distant sites where there is a parietal peritoneum and the patient is not bleeding. So in the case of primary amenorrhea, very important question. And in the case of absent uterus, and in the case of pre-menarchal girls. Okay, I'll tell you what is this. Primary amenorrhea. So the patient has come with the complaints of she's not menstruating only but still endometriosis. Basically, according to Sampson's theory, what happens? She has to bleed and some amount of the blood has to go retrograde. So here primary amenorrhea, it cannot explain. So this unusual site, basically the primary amenorrhea, the uterus which is present or the structure which is having the parietal peritoneum will be converted into endometrium, and that will be functional. So in that conditions, in the case of absent uterus, even though if uterus is not there, parietal peritoneum will be there, so that will become an endometrium and that will be functional. And in the case of premenarchal, that means the patient has not even attained the menarche. Before menarche itself, the endometriosis is happening. That is because of the metaplasia of the parietal peritoneum. So these are the three things which will explain by the coelomic metaplastic theory. And one more important thing that I forgot to tell in the retrograde flow of endometrial tissue is this can also be seen, like this can be even proved by the two important things. One is in the case of obstruction. In the case of cervical atresia, vaginal agenesis. Okay, for example, if you think, so you think this is the uterus. Okay, so here there is a block. So what happens? Whatever the blood is coming here, so that will get accumulated and it will go back. So that means if there's a obstruction for the outflow, that also leads to that of retrograde flow, and that females will have the endometrial tissue in the pelvic region, which has been explained by that of this Sampson's theory. Okay, but whereas this coelomic metaplasia, what does it tells? Even though if the uterus is there or no, whether she is menstruating or no, whether she has attained menarche or no, they will still have endometriosis, because the endometriosis is happening because of the metaplasia of the parietal peritoneum, which is having the same totipotent cells, coelomic epithelium. Okay, so this is the second theory. What is the third theory? Stem cell theory. Here in the stem cell therapy, what they are telling is, generally, you think this is the uterus. Okay, in the uterus, this endometrium, the inner layer of the endometrium, will have two layers. What is this? One is basalis layer, one is functionalis. Everyone knows about this. This functional layers is the one which has been shedding every month, and this basalis layer will generate this functionalis layer. Okay. Now what they are telling is, so this basalis layer of the endometrium here, the basal layer of the endometrium will have little amount of the functionalis layer as well. Okay, so this basalis layer, sometimes if it gets displaced from this of basalis layer, and if it goes some other place, for example, if it reaches to some other parietal peritoneum, and that endometrial tissue will be functional, and that will act as a endometriosis. You got my point? So stem cell theory, basically what does it tells is, undifferentiated endometrial cells which is initially present in the basalis layer of the endometrium will give rise to endometriosis when displaced to the ectopic location. So that is nothing but called as stem cell therapy. So basically what they are telling is, this functional layer which is present, that will get detached, and it will go and it will reach some other place like parietal peritoneum, and there it will become functional, and there it will start menstruating, there it will start forming the bleeding and everything. So all that endometriosis pathology will be happening. So that is what is stem cell therapy. This stem cell theory is basically no one is going to ask an exam on it. And fourth is very important, that is lymphatic theory, lymphatic and vascular spread. The vascular spread. Okay, so here this theory is also called as Halban's theory. Okay, so one more important thing is, this Halban sign can be seen in the case of adenomyosis. Very important. Since I've told Halban's theory, I'm explaining. So what is this Halban's theory telling about? So this Halban is a person who generally explain about this lymphatic spread. This is very easy, and no one is going to ask this also. But still you should know, this is the theory which is explaining about the distant endometriosis. Okay, so there are two theories. One is lymphatic theory, and one more thing which I told you is coelomic metaplastic theory. These are the two theories which is generally explaining about the distant, so the place where the endometriosis is happening in the abnormal locations like the pleura, endocardium, lungs, umbilicus, bowel wall, lymph nodes. All these areas will be happening based on this theory. This theory is explaining what does it exactly like a malignancy. The endometrial tissue generally it will get detached. So this is uterus. So this endometrial tissue generally get detached in the blood vessels as well as the lymphatics, and it will displace and it will get lodged in some other tissues like pleura, pericardium, all this, and that will be functional. So that is about the lymphatic and vascular spread. And next one is immunological theory. What is immunological theory? Is basically, I told you this is uterus. In uterus, what happens? The blood is going backside. This is a Samson's theory. Everyone knows about it. So now what happens? I told you 90% of the females will do all this. 90% of the females will have retrograde bleeding, and in this only 10% will have endometriosis. That's what we discussed. Why in this 90 out of this 90%, 80% are not having any symptoms. Only 10% is having all this endometriosis, because this whatever the endometrial tissue is coming here, all the endometrial tissue is coming here. So this will be cleared. This will be cleared by the immune cells. Very important. What are the immune cells that we have? One is macrophages. Next is NK cells. And third is lymphocytes. So what are these three cells? These three cells will clear all the endometrial tissue which is present inside the pelvic cavity or the dependent part of the pelvic cavity. So now you can tell what about this immunological theory based on this explanation. For the females whose immune cells or immune system is not functional, immune system is not functional or dysfunctional, they will end up having this endometriosis. Okay, so this is about the immunological theory. And next is genetic theory. Okay, what is genetic theory? So basically what they're telling is there is no any proved theories that genetically there is an inheritance. Okay, but based on the research they have told the first degree relatives are having risk of almost 6 times. Important. This is an MCQ asked. Actually, this MCQ was asked in MRC. So, what is the risk factors of the first degree relatives in the case of endometriosis? It is about 6 times. It's a very vague question, but still they have asked this. Okay. And next, seventh one is inflammation theory. This inflammation theory basically doesn't explain about the why the endometrial tissue is present in such locations, but it will explain why there is a pain. Why there is a pain in the endometriosis. That is because I told you, you think this is the uterus. Okay, this is the uterus, and this is the rectum, and this is the bladder. Okay, so now what happens? All the endometric tissue, whatever it is there, that is getting accumulated here in the pouch of Douglas. Okay, endometric tissue is coming here, and backside of the uterus, broad ligament, everything is coming here. Okay, so now the endometrial tissue, once it is coming in the pouch of Douglas, what happens? This endometrial tissue is a foreign body. Obviously, what happens? The inflammation will set in. Okay, the inflammation, there will be fluid in the pouch of Douglas. All this blood, and this blood consists of all the inflammatory mediators. This inflammatory mediators are responsible for the pain. What are the inflammatory mediators? Same thing. One is macrophages, cytokines. Very important. This is very important. Very important. PGE2, that is prostaglandin E2, and of course growth factors, that includes even angiogenic factors. What are angiogenic factors? The factor which is responsible for development of blood vessels. Neogenesis, that means neovascularity. The development of the blood vessels will happen with the help of these angiogenic factors as well as the growth factors. Because of all these inflammatory mediators, especially the prostaglandins, they'll have pain. That is what I explained you in the very beginning of this lecture. That is, they'll have pelvic pain and infertility. You got my point where there is a pelvic pain? Okay. Next is hormonal influence. Hormonal influence. What do you mean by hormonal influences? See, this endometriosis, I told you, this happens especially in the reproductive age group. That means they should be hormone dependent. So what is the major hormone responsible for this endometriosis is important. Endometriosis will be supported. That means will be supported by the estrogen and will be inhibited by the progesterone. Now indirectly you can tell progesterone will inhibit the endometriosis. So we can give progesterone as a treatment. So we'll discuss the treatment as well as the classification in another video. But first we'll discuss about the theories. So this estrogen is responsible for the formation of this endometriosis. That's what I'm telling you. So this estrogen, what happens is the estrogen will be developed. It will be very high in the body. Because of this high estrogen, what happens? This endometrial proliferation will happen, and this endometrial proliferation will happen in such an extent that this endometrial proliferation tissue will be resistant towards the progesterone. So the resistance word is very much important. Okay. So the excess. So what they're telling is here hormonal influence important. Excess estrogen stimulates endometriosis. Okay, which leads to, this is important, they have asked even in Viva, resistance to progesterone. Very important. This is very important. They have asked, this endometrial tissue is very resistant towards the progesterone. So we can give exogenously the progesterone, but whatever the very limited amount of progesterone which has been produced in the body, that won't act on the tissues. Okay, so that's about the hormonal influence. So now, what are the sites? What are the sites of the endometriosis? So I can tell you all sites in the body, all sites in the body will be affected by endometriosis. Okay, endometriosis. But remember, which is the most common site in the pelvic region? This is important MCQ. Most common site is ovary. Okay, so ovary is the most common site. In rest all in the other extragenital region, like it includes GI tract, it includes urinary tract, it includes surgical scars, like previous LSCs, all that. It includes chest and lungs, and even distant also, like meninges, extremities, etc. But important MCQ is this one. Most common site is ovary. Okay. Now, what are the risk factors? What are the risk factors which has been involved with this? See, these risk factors are very much important. They have asked in OSCEs as well. So, one is factor related to the menstruation. So now I'm telling all because of menstruation, this bleeding is happening. Of course, there will be coelomic metaplasia and lymphatic spread, everything. But the core theory why the endometriosis is happening is because of the menstruation. So the females who is more prone for this menstruation are responsible or main cause, I would say, that is the risk factors for development of the endometriosis. So now you can tell what are the main problem with the endometriosis. First is menstruation. In this, either it can be early menarche or heavy menstrual bleeding. And third is polymenorrhea, or we can tell it as frequent menstruation. So they have changed. See, initially they used to tell menorrhagia, but now they're telling us heavy menstrual bleeding. Initially they used to tell polymenorrhea, now they're telling us frequent menstruation. So that. And second, this is about the menstruation. Second thing is about the pregnancy. See, pregnancy basically it's a progesterone dependent condition. So those who have very less pregnancies or those who don't have pregnancies will have high estrogen. So those are responsible for the endometriosis. So very easy. One is no or very few pregnancies. One. Second thing, late first pregnancy. And even after pregnancy, the breastfeeding should be given, because as long as we are giving exclusive breastfeeding, so they will not have menstruation. Lactation amenorrhea will be there. So if they don't give proper lactation, that may lead to, that means absent or less breastfeeding will lead to high risk factors, high risk for endometriosis. Okay, till here people understood, right? Okay. And third one I told you, familial predisposition. So I told you about 6 times. This was asked in MRCOG. Okay, 6 times. Okay. Next, fourth is, interestingly, they will give a history in NEET PG. So if they are telling a female with a very affluent class families, with a high social class family, who is very rich and who is highly educated and who is postponing her pregnancies, so those females are very much risk at developing the endometriosis. So higher social class, so they will not give as higher social class, they'll give as a history, a rich woman or a affluent class woman, like that. And this is a very interesting cause, high risk factor. Fifth one which I'm telling is lean and thin bodies. I seriously have no idea, but still it is given in some books. So I'm just writing this also, but even in exam they have not asked to my knowledge. But according to the logics is excess estrogen. Basically, you can see in the case of obese women. So those should be responsible for developing endometriosis, but unfortunately, the lean and thin bodies are responsible or one of the risk factors for developing the endometriosis. That doesn't mean that you people should take an advantage and gain the weight. So that leads to some other conditions, some other much more worse conditions. So lean and thin bodies is also a risk factor. Okay, and those who are exposed for estrogen. Okay, so these are the things. These are all the high risk factors or risk factors. Okay, now what is the basic pathology? What is the basic pathology? You have to know. See, there are totally three type of lesions. One is superficial, and next is ovarian lesion, and third is deep lesions. Okay, so in superficial also we have early, intermediate, and late. Okay, so these are the types of lesions that you see. See, I'll tell you on basic pathology. You think this is uterus. Okay, this I'll change the color with the proper red color later. Okay, so now this is the uterus. Okay, so now what happens? The blood is going to come like this. Okay, the blood is going to come like this. Okay, now the blood is coming. All this blood is coming. So what happens here in the this? You think this is the peritoneum which is present here. So this blood will come here. Okay, what does this blood consist of? What does the menstrual blood consist of, or the endometrial tissue consist of? Is first thing is glands and stroma. Okay, these are endometrial glands and stroma. Very important. This endometrial glands and stroma, once it comes on the peritoneum, so this will become hormonally active. Okay, hormonally active. Now this blood, what happens here? Endometrial tissue has been present. Now this endometrial tissue will become hormonally active, and this will try to menstruate, and this endometrial tissue will try to menstruate. So what happens? It will proliferate and it will shed. So what happens? Once it sheds, what happens? The old things will be here and new things will be here. Okay, so this what happens in the peritoneum? It appears in the form of a lesion. Okay, so what happens? Initially there will be blood coming out from here, and it will deposit on the peritoneum. After coming here on the peritoneum, this will undergo the pathology. So what pathology? That I'll tell you. Okay, you may take any theories, Samson's theory or a Halban's theory or a metaplasia theory or immunological theory, whatever the theory, the blood is coming and depositing on the, or instead of blood, I would rather say is endometrial glands is coming and depositing on the peritoneum. Okay, now what happens? Once it comes here, what happens? Because of the inflammation, there will be adhesions. So this every point what I'm writing is an MCQ which has been asked in your NEET SS. Okay, one is adhesions. Okay, the adhesions of endometrial implants. So adhesions of the endometrial implants to peritoneum. It's happening. So here what is responsible for this? This is MCQ. The responsible is cytokines. Very, very important. They have asked this multiple times. Cytokines are responsible for adhesions of endometrial implants to peritoneum. So after this, what happens? After adhesions, what happens? Second thing is invasion. There will be invasion of endometrial implants. Okay, so this invasion of the endometrial implants will happen because of which substance. This is also an MCQ, MMP, that is matrix metalloproteinases enzyme. So this is responsible for this. This is also an MCQ. Neat S as they have asked. Third, now after adhesions, invasion, now what happens? It will develop its own vascularity. So the angiogenesis will happen. Angiogenesis of endometrial implants. So now angiogenesis of endometrial implants is happening. This angiogenesis, obviously, everyone know, vasoendothelial growth factor. This was not an MCQ, but still you should remember. Okay, and after angiogenesis, what happens? It will grow, obviously. So it will proliferate. It will proliferate. This proliferate is happening because of the three things. 1, 2, 3. One is growth hormone. Second is increased estrogen. Development of resistance to, as I told you before, progesterone. Got my point? So these are the three things responsible for the proliferation. After proliferation, what happens? From the beginning, inflammation will be there. So inflammation will happen. Come on, guys. Inflammation is happening because of prostaglandins. Yes, very good. What you said is absolutely right. So because of the prostaglandins, there is the inflammation happening. Okay. So these are all. This is the pathophysiology. So in the very beginning, what happens? It will just deposit on the peritoneum, and then what happens? Slowly, it will start developing its own vascularity, adhesions, inflammation, proliferation. So all this will happen. Okay. So now, as I told you, first thing is superficial cells. I told you superficial lesions. In the superficial lesions, there is early. What do you mean by superficial lesions is basically you think any structure. For example, you think ovary. You think this is the uterus and this is the ovary. So now what happens? This endometrial tissue will just deposit on the surface. So all the superficial lesions will be present only on the surface. Okay. Based on its age, based on its time of development, it is classified as early, intermediate and late. Okay. Now tell me, superficial lesions are most commonly seen. Superficial lesions. Independent part, that is pouch of Douglas, posterior surface of uterus, utero-vesical pouch, and uterosacral ligaments. Okay. So these are the four important things. They have not asked this in an exam, but still you have to remember, especially the Samsung's theory is supported by the superficial lesions. Okay. Now, I told you early lesions. So early lesions basically very important. Early lesions they have asked in exam. These early lesions are nothing but called red or pink vesicles. Red or pink vesicles. Generally, this vesicles is nothing but filled with hemorrhagic fluid. That means blood filled. Hemorrhagic fluid. So early lesions are either red or pink. Okay. So how does it appear? This is an MCQ. It appears as red flame shaped lesions. Okay. Red flame shaped lesions. So this is nothing but called as early lesions. Very, very important. They have asked in exam red flame shaped lesions. But nowadays what they're asking is imaged based. So how does it look? See, you can see here this lesions which is red or pink, which is flame shaped, and it's like a vesicle, and which is nothing but called as hemorrhagic. It blood filled. So this is the early lesions that you can see. So in intermediate lesions, what happens is the intermediate lesion basically it appears as brown. So you can see this is intermediate lesions, which is brown or bluish or black with time. So this is intermediate lesion. This is intermediate. And this is early. So see, remember there is a hack. Early intermediate, late. Okay, early is red or pink. Late is always white. It's nothing but called any color which comes, it will be intermediate. It may be blue, or it may be black, or it may be brown, or any color that is basically intermediate. So early and late is generally red and pink, and this is white. This is what you remember. This is what you people should remember. And this, obviously, any other color, it comes under intermediate lesion. Okay. So now this superficial lesions, I told you it is very superficial. So can we palpate it on per-vaginal exam, per-abdominal examination? No, we cannot palpate it. So in vaginal examination, this is an important MCQ. Cannot be examined. Okay, cannot be examined. So for example, if they ask you in the NEET PG, a patient with complaints of chronic pelvic pain has come to OPD, and on per-vaginal examination, you can see a nodule-like structure which is present in pouch of Douglas. So what type of lesions? So if they ask superficial lesions, it is absolutely wrong. Superficial lesions cannot be examined because they are very superficial and you cannot palpate it. Okay. And interestingly, these superficial lesions cannot be even be diagnosed with the CT or USG or MRI as well. So how can you diagnose superficial lesions? The only and only way by directly looking at it. How? By laparoscopy. Okay. So this is MCQ, guys. This is MCQ. The diagnosis of superficial lesions can only happen by laparoscopy. So this, all the things cannot identify superficial lesions. Got my point? Next is ovary. See, as I told you, this is ovary and superficial lesions will be on the surface. But if the endometrium tissue is invaginating, inversion and invagination into the ovarian cortex, that leads to the it's called as endometrioma. It's called endometrioma. Okay, it's called as ovarian endometriosis or endometrioma. So what happens? This endometrial tissue, these two words you have to remember. One is inversion and next is invagination. So if there is a inversion or invagination of endometrial tissue, when you're writing university exams, this is important. Endometrial tissue into the ovarian cortex, that leads to this endometrioma. Sometimes what happens is this ovaries will be sometimes a cyst, functional ovarian cyst. So this implants, if it goes and it forms a endometrioma. Okay. So this, for example, this ovary, generally this endometrium develops into, it is developed on the anti-mesenteric surface. Anti-mesenteric surface. It leads to anti-mesenteric surface. Development happens generally on the anti-mesenteric surface of the ovary, causing to the adhesions. So this leads to adhesions too. Where it leads to adhesions, which all structures? The surrounding structures, obviously, to uterus, to broad ligament. This is broad ligament. BL means broad ligament. Okay, and other structures as well. Okay, so now this endometrioma is also called as, interestingly, it is also called as chocolate cyst. Okay, this is called as chocolate cyst. So this is chocolate cyst. See, generally we think chocolate cyst, it looks like a chocolate. No, but actually the surface is white. Okay, only after opening it. So this is a laparoscopic view. So now this is the ovary and this is a chocolate cyst. So what happens? They have removed this outer surface, and after opening it, you can see a dark chocolate fluid coming out. So the inner fluid is chocolate in color. Okay, this is called as chocolate cyst. That means ovarian endometrioma is also called as chocolate cyst. So why does the fluid appears as a chocolate color? It's nothing but called as, it's a past blood secreted. So it's a past blood secreted by, obviously, endometrial glands. Okay, so the chocolate colored fluid is seen. Sometimes what happens, these two ovaries, because of the multiple inflammation which is happening on this ovary also, that ovary also, what happens, these two ovaries will come and attach with each other. Okay, you think this is the ovary, this is the uterus, and here is the ovary, and here is the ovary, which will enlarge, and finally this will approach each other, and the what happens, two ovaries will come and attach like this. Okay, so these two ovaries coming and attaching with each other because of the inflammation, because of the adhesions of endometriosis, and this is nothing but called as kissing ovaries. It's called as kissing ovaries, which is seen in the case of endometriosis. Endometrioma to be specific. Okay. Okay, so now since the ovaries are so huge, obviously you can feel it during vaginal examination. Of course, when you're keeping the finger into the vagina, and you can see the fornix is having a mass. It's nothing but called as this ovary, which is big and enlarged. So this ovary, sometimes what happens, it may undergo torsion, it may undergo rupture. Okay, cyst rupture can occur. So these are the complication of this. So this can be easily diagnosed with the help of like clinical examination. Clinical examination can be done. Okay, and then CT, and then MRI and USG, all these things are used to diagnose the endometrioma. Understood? Okay, when you're identifying endometrioma, you can also identify multiple nodules which is present on the various structures, which is nothing but called as endometriotic tissue, which has been deposited on the uterosacral ligament or other peritoneum like uterovesicle. All the structures will be having a small nodules, even the posterior side of the uterus or the broad ligament, all the structures. Okay, next is deep endometriosis. Deep endometriotic. I told you deep endometriotic lesions. Generally, what happens? This basic pathology, what I have told you, what I have told you, what happens on the long-standing conditions? This will infiltrate and it will go deeper and deeper and deeper. You think this is the structure? Initially, endometrial tissue will be superficial and it will become aged. And what happens, because of the vascularity, because of inflammation, what happens? That will grow, that will become deeper, deeper and deeper. Okay, so if it is going deeper, that is called as a deep endometriotic lesions. So now there should be some standard landmark, like how much is called as deep. So if this is an MCQ, they have asked if the depth is more than 5 mm. If the depth is more than 5 mm, then it is considered as deep endometriotic lesions. Okay, now there is a specific structure which these deep lesions are especially present, where there is a very there's a vascularity and there is a lot of space that will penetrate, especially the recto-vaginal septum. Of course, bowel, ureter, bladder, rectum. Okay, you think this is the bladder. Okay, this is the uterus, this is the rectum. Okay, so what happens, this is the peritoneum which is present like this. Okay, so this is what the peritoneum now which is present. This is the structure I've showed you before in anatomy. Where is that? This is the. Now, recto-vaginal pouch. So this is the pouch. Okay, so what happens, this endometrial tissue will be present here and it will spread. I'll use a red color. So it will spread and it will reach the rectum as well. So endometrial tissue, pura, it will come and it will infiltrate. Okay, so here it will infiltrate the bladder as well. Here the bladder. Okay, so here is the ureter. This is the ureter. So sometimes it will infiltrate into the ureter as well. Okay, and there is a bowel here. So it will infiltrate into the bowel as well. This is the bowel. Okay, so all these things, all this generally it happens in the case of the deep lesions. Okay. So all the structures here, rectum and bladder and ureter will be coming here. For example, if this is the ureter, so here also this will go infiltrate into the ureter. All this structure. So especially these are all present in the pelvic region. Am I right? So they'll have a chronic pelvic pain, dude. It's very very painful. Chronic pelvic pain. They'll have chronic pelvic pain. So what is the depth? Now what are the important things that you have to remember is all the structures you have to remember, and very importantly I told you the depth of 5 mm. Okay. Now I'm telling you the lesions is going here, it is going here, it is going here. Okay. Now what happens here, the inflammation will set in, right? So what happens, this will become narrow, this will become narrow because of the inflammation. So they'll have constipation, because of this inflammation. Sometimes they'll have loose stools, sometimes that will bleed, so they'll have blood in stools, and they'll have hematuria. All these conditions can be seen. Okay, so how can you identify here also, since it's a deep things and tender nodules will be there. So see, this is all pouch of Douglas, like pouch of Douglas. When you do pervaginal examination, you can see the nodules here, nodules, pura nodules, it's there like this. Okay, the nodules can be seen here, all can be seen. So when you're doing the pervaginal examination, you can see all this nodule like structure which is present, and these nodules are generally tender. This is a pouch of Douglas. Now when you're doing pervaginal examination, you keep the finger here, and these nodules are tender, and this can be seen. So thing is, we can do examination, clinical examination can be done just like ovarian endometrioma, and CT, MRI and USG can also be used to identify this one. Okay, so this is about the pathophysiology that has been happening. Okay, so now microscopically what will happen? Microscopically, I told you what is the composition of this endometriosis. Obviously it should be a endometrial, come on guys, endometrial glands. I told you glands and stroma should be there. Along with this, there is also very important structure called as macrophages. I told you inflammation. These macrophages will be having hemosiderin. So hemosiderin laden macrophages, very important. So hemosiderin laden macrophages will be there, that can be seen in the case of the microscopy. So endometrial glands, stroma, macrophages are the microscopic findings of endometrial tissue. So this hemosiderin laden is nothing but called as the RBCs. The RBCs will be broken. All this are engulfed RBCs like hemoglobin. So that is nothing but called as macrophages. These macrophages will be engulfing all the hemoglobin which has been present in that blood. So all these three are the composition of the endometriotic tissue. And in the case of deep lesions, what are the other things that you can see? In the deep lesions, one is dense fibrous tissue as well as smooth muscle glands. These are two things that you can see in the case of deep lesions. Okay, that's about the histopathology. So now, what will this endometriosis enter into malignant form? Malignancy. Will this form into malignancy? Actually, very rare. Very rarely, this endometriosis will end up being a malignant lesions. What are the things that you can see? Obviously, I told you this endometriosis is nothing but called as the estrogen dependent. So now what happens? Estrogen dependent malignancies. Come on, guys. One is clear cell carcinoma, and next is endometrioid. So we'll discuss this in detail when we are doing malignancies. So the clear cell carcinoma and endometrioid carcinoma, these are the two things. And low grade ovarian adenocarcinoma also. But I'll tell you, these are very rare. Okay, these are very rare. But to remove this remote complications also, what does we do? So what do we do is, we do total abdominal hysterectomy with bilateral salpingo-oophorectomy is usually performed, is the actual treatment of choice for perimenopausal. Okay, perimenopausal women. Okay, what are the other rare cancers that you can see? What are the other cancers that you can see which has been associated? Is one is ovarian, as I told you. Apart from ovarian, breast and thyroid. breast and thyroid, but very rare. So what are the things that you have to do? You have to do lifestyle modification, balanced diet, all these things should be done to prevent this malignancies. Okay. Now